At the exact moment of birth, a neonate undergoes a severe physiological shock. The umbilical supply is severed, and fetal circulation must instantaneously transition to pulmonary gas exchange. Fluid is driven out of the alveolar sacs to make way for air. For 90% of newborns, this transition happens seamlessly. Roughly 10% require some form of respiratory assistance to complete the process, and exactly 1% demand extensive, invasive resuscitative measures to survive it. This creates a strict dividing line between adult advanced cardiovascular life support and neonatal care. When an adult crashes, it is typically a primary cardiac event. When a newborn fails to transition, it is almost entirely a respiratory problem. This target oxygen saturation table shows a newborn is naturally hypoxic at birth, taking 10 full minutes to reach normal oxygen levels. Forcing pure oxygen immediately causes cellular injury. We must titrate to these exact physiological targets. The baseline objective of neonatal resuscitation is not to shock a stopped heart. It is to mechanically optimize a failing respiratory transition over a highly unforgiving timeline. This flowchart is the NRP algorithm, serving as the ultimate critical escalation matrix for infant survival. Its structure forces practitioners through rapid binary decisions, yes or no, dictated entirely by the infant's vital sign feedback. The upcoming 2026 protocol updates adjust how this algorithm is executed in the delivery room, introducing significant tactical shifts. The core philosophy of the new guidelines moves away from rigid chronological sequencing. Instead, it demands flexible interventions driven strictly by the patient's real-time physiology. However, the entire escalation process remains fiercely governed by two non-negotiable physiological thresholds: the heart rate dropping below 100 beats per minute and the heart rate dropping below 60. The 2026 updates grant clinicians wide tactical flexibility, but the timing of those tactics is entirely locked to these two hard physiological data points. Looking at the top of the matrix, the very first intervention point occurs immediately following birth, before any physical assessment of the infant is even made. The 2026 standard increases deferred cord clamping to at least 60 seconds, maximizing blood transfer. If impossible, cord milking is an acceptable alternative for term infants. However, cord milking is strictly contraindicated for extreme preterm infants before 28 weeks, creating severe risk of brain bleeding. Once the cord is managed, the pre-ventilation window hinges on 3 rapid-fire assessment questions. Is the infant term gestation? Is there good muscle tone? Are they breathing or crying? If the infant is not actively failing these checks, the most effective initial resuscitation is measured in action. The first minute prioritizes uninterrupted placental support. A no to the initial assessment leads to the first major failure threshold. An active heart rate under 100 beats per minute immediately aborts routine care. At this exact metric, the team must intervene mechanically by initiating positive pressure ventilation, or PPV. The updated parameters for this golden minute broaden the acceptable ventilation rate to between 30 and 60 breaths per minute, while standardizing the initial peak inspiratory pressure at exactly 25 centimeters of water. Because deferred cord clamping takes longer, the rigid 1-minute oxygen target is eliminated. Instead, initial oxygen concentration scales precisely to gestational age. Term babies start at 21% room air, while preterm infants begin up to 30%, adjusting strictly by pulse oximetry feedback.
Ventilation is treated as a continuously titrated therapy of pressure and oxygen, precisely tailored to the infant's specific gestational maturity. If positive pressure ventilation is initiated, but the heart rate remains below 100 beats per minute, it indicates inadequate chest rise and an obstructed airway. To correct this, generations of practitioners were taught to rigidly follow a specific mnemonic, MRSOPA. The acronym historically demanded a strict sequence: adjust the mask, reposition the head, suction the airway, open the mouth, increase pressure, or an alternate airway. The 2026 protocol actively discourages blindly following this sequence in order. Clinicians are now mandated to bypass steps entirely. If a physical obstruction is obvious, the practitioner must immediately jump to the intervention most likely to solve it, rather than wasting time adjusting a mask. By dismantling the sequence, the protocol prioritizes clinical judgment over rote memorization to save precious seconds during a hypoxic crisis. The algorithm's most dangerous physiological threshold signifies impending cardiac collapse. a heart rate dropping below 60 beats per minute. Falling below 60 despite effective ventilation proves the pulmonary transition has completely failed. The clinical team must now physically take over both cardiopulmonary functions. Securing an alternate airway via endotracheal intubation is required immediately. This chart dictates the sizing, which must be absolutely precise down to the half millimeter, mapped directly to the infant's weight and gestational age. Once the airway is secured, the team executes an aggressive biomechanical override, initiating chest compressions at a strict 3-to-1 ratio. At this depth of the crisis, the concept of titrated oxygen is abandoned entirely. The FiO2 is instantly maximized to 100% pure oxygen. The 60 beats per minute threshold is the end of physiological assistance. It is a total mechanical override designed to artificially force oxygenated blood to a dying myocardium. The final, grim loop of the algorithm is reached if severe bradycardia persists below 60 beats per minute, despite flawless intubation and coordinated compressions. This requires immediate emergency vascular access. In a collapsed neonate, the quickest route for drug administration is directly through the umbilical vein. The required chemical agent is epinephrine. It functions as a potent vasopressor, aggressively constricting blood vessels to force coronary perfusion. The administration requires highly specific concentration and dosage parameters between 0.01 and 0.03 milligrams per kilogram to ensure clinical efficacy while preventing a toxic overdose. Pharmacological intervention is a chemical hammer, utilized solely when mechanical pressure and pure oxygen fail to restart the engine of the heart. This complete flowchart maps a precise descending sequence. Every step is designed to reverse hypoxia before irreversible primary cardiac failure occurs. The 2026 updates demand that practitioners operate with tactical flexibility within this structure, prioritizing the dynamic biology of the infant over a blind step-by-step procedure. But the protocol also defines a stark final parameter. If there is a confirmed absence of a heart rate after 20 minutes of intensive resuscitation, the clinical team must evaluate stopping all efforts. The 2026 Neonatal Resuscitation Program is an algorithm of applied physiology. It demands intense clinical judgment, governed absolutely by the relentless ticking of the clock and the vital truth of the 160 beats per minute thresholds.